Hello, everyone from wherever you're joining us in the world. Thank you for joining us on this GLODAM Trainee Committee webinar. Today we have our webinar on skin and sexual health challenges affecting displaced persons. And these are our hosts for today, our speakers for today, Dr. Valeska and Dr. William Abou. And we'll go into a lot more detail on their bios in the next slide, where the topic is skin and sexual health challenges affecting displaced persons. So our hosts for today are myself, Karen Waithera. We also have Fortunate Raymond McCoy and Stembiso Mlanga. So just to go over some ground rules for the webinar, GLODAM Trainee Committee, or the GTC, is part of the International Alliance for Global Health Dermatology, also known as GLODAM, and the International Foundation for Dermatology, the IFD. Our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. And we have many initiatives, but our key initiatives are educational webinars where we provide free, high-quality learning opportunities. We also have networking and collaboration initiatives where we connect trainees worldwide. And we have a podcast series that is available online for free, where we address challenges in global health dermatology. So as part of our meeting etiquette, kindly ensure that your audio is muted and that your camera is turned off. It will be turned off automatically for the duration of the webinar. Also, if you have any questions, kindly submit them via the chat or the Q&A function, and we'll ensure that our hosts are able to respond to your questions or your comments at the end of the webinar. We'll also be sharing further information about the GLODAM Trainee Committee in the chat function. So about our hosts, our speakers for today, you can see them here. This is Dr. Valeska. She's a dermatology and venereology consultant and also deals with the Department of Dermatology and Venereology in Malta. She's also the co-founder and for Bridges at Two Health and Rights. And then we also have Dr. William Abou, who's the medical doctor and second-year research fellow at the American University of Beirut. And he's also an active member of the Migrant Health, Skin, and IFD or ILDS community. So over to our speakers for the day. Thank you.
Good afternoon, everyone. My name is William, and thank you, Karen, for the introduction. Thank you, GLODAM and ILDS, for the invitation, and for Dr. Valeska also to be a co-speaker with her today. I will be presenting clinical cases. So my overview is a short introduction and key challenges we faced in the refugee camp. I will go through clinical cases that we thought that they are challenging, and then I will conclude with take-home messages. So displaced populations, including refugees and internally displaced persons, face significant dermatological and sexual health challenges. The three major contributors to dermatological cases include poor hygiene, which increase the risk of infections, overcrowding, and we saw through many cases of scabies where the whole family share the same room. And it was also hard for us to isolate the patient. And while hygiene and living conditions are major concerns, access to medical care remains the biggest challenge, leading to undiagnosed and untreated condition. In the Bekaa, where the refugee camps located, very few dermatologists work there, and many displaced individuals cannot see a dermatologist until their condition becomes severe. Additionally, they may lack access to essential medications, leading to prolonged suffering and complication. Today, I will explore this challenge, focusing on a critical clinical cases, and I will go directly into case one. It's a case of a 35-year-old refugee presenting with an unhealing ulcerated skin lesions on the wrist and feet. The symptoms began 2 months ago as a small erythematous papule, which progressively ulcerated over time. And the patient reports no significant pain, though occasion itching is noted. There are no accompanying systematic symptom, such as fever, nor any history of previous similar lesions. So the differential diagnoses were here for the presentation include actually bacterial infections such as cutaneous tuberculosis and ectema gangrenosum, fungal infection like sporotrichosis, and that should also be considered, particularly in cases where nodular lymphogenetic spread is observed, and additionally autoimmune conditions such as pyoderma gangrenosum. The examination revealed a well-defined ulcer with raised erythematous border. The ulcer has a central crusting, necrosis, and mild serous discharge. There is no evidence of lymphadenopathy or other symptom, as I said. The patient is living in overcrowded refugee camp with poor sanitation and high exposure to sandflies. So the diagnosis is confirmed by biopsy after a week in the American University of Beirut Medical Center, showing Leishmania amastigotis. So what is the cutaneous leishmaniasis, which is a parasitic disease transmitted by sandflies infected with the protozoa Leishmania? And it is endemic in many countries, like more than 70 countries, and affected an estimated 12 million people. There are several clinical forms, and it depends also on the geographical location. Who gets it? Usually people of all ages, but specifically people living in rural areas and spending time on river or near the ground that increase the risk. Cutaneous leishmaniasis is the most common form. And for the diagnosis, it's based on the history and the clinical appearance of the lesion. A comprehensive travel history, including historical travel due to the long incubation period, is important in the non-endemic areas. The diagnosis can be confirmed by identifying the parasite on biopsy or split skin smear. Culture and PCR may also be used to identify the species of Leishmania, which is important when there is a risk of mucocutaneous leishmaniasis. Serology is used to confirm the diagnosis in visceral leishmaniasis. I will go to the second slide to talk about the treatment. So the first-line treatment for this condition, it include pentavalent antimonials, and it's usually administered intravenously or systematically, and depending on the size and number of the lesion. As an alternative, it comes the oral miltefosine, which can be used if available. And local therapies such as cryotherapy or thermotherapy may be considered as adjunctive treatment in such cases. Which is here, it's really important for us to discuss the challenges that we saw, and specifically during this case, which is the limited availability of diagnostic tools. Yes, we didn't have thermoscopy, PCR, biopsy, or surgical intervention, which make the definitive diagnosis really difficult. And the delayed presentation is further exacerbated by the lack of the dermatologist, meaning the patient had to travel to Beirut, which is a 2-hour drive for a biopsy or to wait for the result. Additionally, the poor hygiene increased the risk of secondary bacterial superinfection. And this is not possible to be avoided because of the isolation. We couldn't isolate patient because they all share more or less a single room. Finally, the loss of follow-up remains a major concern. In this case, we were unable to confirm whether the patient was fully cured as they didn't return for further evaluation. In the case 2, which is a patient of 45 years old, refugee from the Bekaa, who presented with a non-healing ulcerated skin lesion on the tip of the nose. The symptoms began 3 weeks ago as a small, painless nodule that progressively into a non-healing ulcer. Over time, the lesion increased in size, developed on irregular border, and failed to heal. There are no associated symptoms or fever. The lesion appeared as a large irregular ulcer with raised indurated edges. The base is necrotic with minimal discharge. There's sign of chronicity and evident, including the hyperpigmentation scarring around the lesion. Additionally, there are signs of bacterial superinfection, such as warmth and excessive tenderness in the area. However, there is no evidence of other symptoms. A closer look under the dermoscopy was needed to further assess the lesion, giving the sign of bacterial superinfection. The patient was started directly on those prolonged course of doxycycline, and then he was referred to the AUBMC again for a biopsy to confirm the diagnosis. Unfortunately, like many cases, we lost follow-up with the patient. So here we were into the diagnostic dilemma between cutaneous leishmaniasis, non-melanoma skin cancer, BCC or SCC. A confirmatory testing via biopsy or histopathology is necessary here. And PCR for leishmania is also good to be used if leishmania is suspected. Dermatoscopy, if available, which is the easiest way to differentiate between these three diseases. So the chronic cutaneous leishmaniasis remain a strong possibility as well, given the ulcerative form persisting due to the lack of timely treatment. Squamous cell carcinoma is another important, as I said, differential diagnosis here, and given the location as well of the disease. Basal cell carcinoma should also be considered, especially if the lesion presented on a pearly border and central ulceration. Lastly, keratocantoma remains a possibility, given its chronicity and rapid growth, dome shape, and central keratin plug, as you can see in the picture. So, if the lesion were diagnosed as skin cancer, the ideal treatment would be surgery, excisional surgery, provided if it's feasible as well, Mohs Mohs surgery or Mohs micrographic surgery. But it wasn't available, of course, in the refugee camp, nor in the Bekaa. So here are the challenges that we also face on during this case, which was the early loss to follow up, which increased the risk of disease again, progression and complication. There is limited access to essential dermatological tools, biopsy, histopathology, making it difficult to establish an early and definitive diagnosis. Additionally, the surgical and oncological care is lacking, not only within the refugee, but on the whole area. So this geographical limitation further delays the intervention, as patients must travel long distance for specialized care. And lastly, there is a critical need for awareness campaigns focused on chronic wound and skin cancer screening, where many refugees work long hours under the sun during the summer month, putting them at a higher risk of developing sun-induced malignancies. And early recognition and the treatment could significantly here help us to find the right diagnosis. This is my last case, which is case 3 of a 40-year-old patient present with an intensely pruritic genital ulcer that has persisted for 3 weeks. The lesion initially started as a small papule and progressively ulcerated over time. The patient denies fever or other symptoms. However, he reported engaging in unprotected sexual intercourse 1 month before the ulcer appeared, actually. On examination, there is an erythematous excoriated ulcer on the glans penis with the crusted, scaly border, showing signs of chronic scratching. Surrounding papules and burrows are also noted. Mild inguinal lymphadenopathy is present, but there are no vesicles, grouped ulcers, or urethral discharge. So as first, the differential diagnosis here comes the STIs, are a common cause of the ulcerated lesion in male. Genital herpes, which is typically present with painful grouped vesicle, which is automatically here ruled out clinically. Then syphilis begins with a painless indurated ulcer or a cancre at the site of the infection, often in the genital, anus, or mouth, and is diagnosed using the serology test. also clinically ruled out, and cancoid present with a painful soft ulcer with a purulent base, typically a characteristic of a school of fish under gram stain. Other differential diagnosis, which is part 2 here, the non-STI causes in males. I will go briefly over the fixed drug eruption, which is characterized by a single recurrent erythematous ulcer that appears as at the same size each time, and typically triggered by certain medication. NSAID, sulfa drugs. Another important consideration, Behçet disease, which present with painful recurrent genital and oral ulcers, often accompanied by a positive pathology test. At the end, I would like here to focus on the nodular and crusted scabies, which can mimic ulcerative condition, as it causes highly prolific lesion that may ulcerate due to persistent scratching. The presence of burrows on the other body part and confirmation through positive microscopy and dermoscopy aid in the diagnosis. While the clinical presentation here may overlap with other conditions, scabies remain the confirmed diagnosis in this case, as all other differential have been ruled out clinically. Sorry. So in a proper clinical setting, given the genital ulcer, we needed to rule out STI before anything else, as I said. And here the dermoscopy in this case will reveal certainly mites, scabies mites or eggs, and a skin scrubbing under the microscope will confirm the persistence of mites, leading to a definitive diagnosis of genital scabies. We all probably know the management of scabies in refugee setting, starting with topical permethrin, oral ivermectin, and antihistamine to avoid a severe pruritus. We need to treat close contacts and the sexual partners, and also an environmental decontamination with putting all the items in a bag for 72 hours and isolating them. So here the challenges might be similar also as before, but I would like to highlight that overlapping clinical presentation with sexually transmitted infection, many cases are misdiagnosed, especially when treatment is given empirically. This often leads to unnecessary antibiotic use, contributing to the growing problem of antibiotic resistance. There is limited access to medication, particularly the ivermectin here, which makes the challenging cases, and the widespread of this of scabies within the refugees is growing. And another key issue is the stigma associated with the genital ulcers, which can prevent male patient from seeking medical care. I would conclude my presentation with a take-home message. We've covered a range of dermatological conditions commonly encountered in our displaced population, from infectious dermatosis to non-infectious diseases. While our focus has been on diagnosis and treatment, prevention through basic hygiene and early intervention remains crucial. And addressing these challenges in a displaced population require a combined effort, really from healthcare providers, NGOs, and policymakers. By improving access to dermatological care, we can reduce the disease burden and enhance the quality of life for these vulnerable communities. My last message is looking ahead. We hope these medical challenges become memories of the past, as our ultimate goal is to see our displaced people return home. Until then, we continue our work. Thank you.
Thank you. I think I can share my screen now. Thanks, William. A very, very nice presentation. Well done. Congratulations. I try to share my screen if I manage, if I see it. Here we are. Okay, can you see the screen?
Yes, we can see your screen.
Okay, let me put down this. So we'll continue talking about public health interventions to increase access to skin and sexual health in migrants and displaced persons, focusing mainly in two countries where I work. One is the country where I live, Malta, and the other country is Lebanon, where I met Dr. William, and where we are working in a teledermatology project. This is my outline. I start quickly. So I give you an idea. I see that many of you come from different countries around the globe. So I'm very happy here to be here today and to talk in front of such an audience. It's amazing. And thanks a lot, Gloderm, for inviting me to this webinar series. This is a photo of the beautiful country where I live. I'm Italian national, but I live in Malta. Malta is a small island, a very tiny island, and it is also the southernmost European regional state in the heart of the Mediterranean Sea. A very new feature of Malta is the number of international migrants. And when we talk about migrants, we refer to people that were born in a country different from the country where they live. So myself, according to this definition, I'm considered a migrant. And in Malta, the last census was done in 2023, and it showed that the 28% of the total population was migrant. So 1/3 is really a big number. And again, this map is to give you the idea of where we are placed. So you see the African and North African shore, and this is Libya, and Italy, Sicily, the southern of Italy, and Africa. In the middle, we see Malta and Lampedusa, two tiny islands, which both of them face a high number of migrants arriving by boat from Northern Africa, so from both Tunisia and Libya, in the direction of Italy. Lampedusa is a small island, very, very famous. Probably also you heard about Lampedusa because of boat arrival, dramatic boat arrivals, very huge numbers, and also huge number of people who die while they try to cross the Mediterranean Sea. And the same for Malta, which is another European member state, separate, different from Italy. So it's very important to point out that migrants at arrival, especially when we see them arriving by boat in our country, they are mainly healthy. So we are talking about health and migration, but I want to point out this important aspect of migration. So only young and healthy people usually move in looking for a better life. Obviously, this doesn't apply to refugees or to people who escape from the country of origin because of war or because of conflict, and they seek for asylum to another country, or because they are displaced because of war. So this doesn't apply to refugees. But in general, migrants, mainly economic migrants, are healthy. And usually we say that they are also healthier of the domestic-born population. But these immigrants' healthy effect usually decrease in relation to the length of residency experience by migrants themselves, also because some of them fall sick because of the social determinants of health, so the living condition they experience in the hosting country. Many of them move back to the country of origin. This is also called Solomon effect. I give you an idea of what we do when migrants arrive. This is our reception center. So there are centers where migrants are first screened for medical issues. And we often, we are a small country, few medical doctors, many from public health who are dealing with communicable diseases in this case. And we don't have people translated, so the so-called cultural mediator. We don't have the luxury of having the cultural mediator coming from the country of origin of migrants, helping us translating from the different languages and cultures. And so we use photographic material like this. The main screening is based on syndromes or respiratory infection, mainly cough to exclude the TB, diarrhea, gastroenteric symptoms, and skin itching, as you can see in this photo. Migrants are mainly healthy, I say, but some of them fall sick during their trip. You see this photo show how migrants travel across the Mediterranean Sea. Big, overcrowded boats, look, a huge number of migrants who cannot go to the toilet. They are all sitting for many hours, sometimes for many days, while they attempt to cross the Mediterranean Sea. Or big truck crossing the desert, and few people know that 12% of migrants crossing the desert die during the crossing. Those who survive, usually they remain in detention center in Libya, and they really live in poor condition, which affect their health. And one of the most common problems we face at migrants' arrival is scabies. In this study in Lampedusa, when I was working there with the National Institute for Health and Migration of Italy, we found that more than half of migrants arriving were affected by scabies and other skin infections. And again, important screening for these before migrants enter the reception center in our countries, because these are communicable disease. And another big issue we are facing with migrant skin infection, mainly scabies, is now the resistance to common treatment. There are many reports, and reports are on the rise about treatment failure with a classic treatment like permethrin or other scabicide. And we have to increase the use of oral ivermectin, or maybe to extend the duration or increase application of topical permethrin. We recommend to leave the permethrin instead of 8 hours for 24 hours, or repeat application instead of day 1 and 7, also at day 3. Another important things we are doing together with the Migrants Health Working Group of the International Foundation for Dermatology is collaborating with WHO on this important project, Skin Neglected Tropical Disease, to address imported rare skin infectious disease also in migrants and refugees. So we're collaborating with WHO to this app to detect, to help to educate about detecting skin sign of tropical diseases, neglected tropical diseases, and also to develop an artificial intelligence app. We saw a case with Dr. William about cutaneous leishmaniasis. This is another case I encountered in a migrant coming from Ethiopia. You see the classic nodule or papule or plaque on the skin with a central crust in a photo-exposed area. So it is transmitted, is a vector-borne disease transmitted by the bite of the sand fly. And what we have done in Malta, because my talk is mainly of public health intervention, something we are trying to do to understand better the needs of migrants in terms of skin and sexual health, we wrote a project, and we managed to get funded from the European Academy of Dermatology and Venerology. And I briefly present you the project SCAP. SCAP is an acronym, meaning Skin and Sexually Transmitted CAP Survey, Knowledge, Attitude and Practice Surveys, and their promotion strategies in migrants coming mainly in Malta, arriving in Malta, or displaced people in Lebanon, mainly in the Bekaa Valley. These are the two settings, the two countries when we run this project. Investigating skin and sexual health. The project finished in 2023 in Malta, but is still ongoing in Lebanon, where we also implemented a component of teledermatology. The aim of this project, as I say, was to investigate skin and STIs prevalence and running a CAP survey in migrants and refugees, to explore forms of sexual and gender-based violence and access to sexual health services for migrants in the two countries of the project, and to explore the use of teledermatology support of skin and sexual health in migrants and displaced people. This is the map of Malta with the reception center where we work. And in Malta, we also managed to work in detention centers. So many migrants are after arrival or because irregular in the country are put in detention before being deported. And so we were the only doctor working also in detention centers. I go quickly about the methodology. I want to stress the fact that we were working together with cultural mediator. As you can see in this photo, there is a cultural mediator usually cultural mediator are migrants themselves coming from the country of our patient, our migrants population, and they're helping us to bridge not only with the language, but also with the culture of the migrants. So, and they managed to understand and to translate also important cultural gaps. I go quickly to show you some data. I work at the sexual health clinic in Malta, and every year we see around 10,000 patients. A big number of our patients are migrants coming from low and middle income countries from around the world. I count over 160 different nationalities every year. And I don't want to focus too much on these numbers, but about the analysis and the result of this study show that migrants coming from low and middle income country seen during our outreach clinics and also the GU clinic were mainly men and young men between the age of 30 and 59 of years old. Whereas in Safi detentions and the detention center, we visited mainly younger patients between 15 and 29 years of age. This slide showed the sexual orientation. Migrants seen during the project were mainly heterosexual, so young men and heterosexual. And according to this table, migrants from low and middle income country usually presented with symptoms to our clinic or during outreach clinics. They were mainly symptomatic. And in this table, you can see that compared to the intra-European migrants, migrants from low and middle income countries present late to the service only when they have symptoms because there is a lack of awareness of prevention. So this is one of the first points that emerge from our research, that there is a lack of prevention and a lack of awareness concerning sexual health in migrants population. This table shows the result of our project concerning the prevalence of sexually transmitted infection, mainly chlamydia, syphilis, gonorrhea, trich, HIV, scabies, and also mpox in the migrants population, in particular in migrants coming from low and middle income countries compared to the intra-European migrants. And again, we see that the p-value is the difference is significant statistically in migrants from third country compared to intra-European countries. So again, migrants arrive late to our service, they present with more STIs, and usually there are more complicated cases. And there is, again, lack of knowledge, lack of education, a very high risk of stigma. I mean, according to the survey result, we saw that there is a lot of fear of being verbally abused or sidelined by family or by friends if diagnosed with HIV infection. So there is a lot of stigma against STIs and perceived stigma against STIs and HIV from this population. I would like to show you this case just to give you an idea of what we are talking about. A 32 years old man identifying himself as bisexual from Togo, presenting with an acute uveitis to the ophthalmology department, presenting also with a skin rash, but it was not complaining about the skin rash, presenting mainly with a problem, a visual problem, and that's why he seek for medical care. He was then referred to our clinic because the ophthalmologist ran a syphilis test, and the syphilis test, as you can see in this result, resulted positive with a high VDRL over 12256. He was screened at the sexual health clinic, in the clinic where I work, and he also resulted hepatitis B positive and HIV positive. So this was a case of secondary syphilis with a neurological involvement, so neurosyphilis and hepatitis B and HIV co-infection. Just to show you what I mean when I say migrants present late to the service, only when they are symptomatic and when usually there are multiple comorbidities, like in this case. In Malta, we have decentralized sexual health service to increase and facilitate the access to our sexual health clinic, also to migrant population. We support the primary health care community clinics training GPs, general doctors, also in sexual health. And now we are running also a project, namely Reach Out, via mobile clinic to reach out to the hard-to-reach population, mainly migrants and other vulnerable group, offering sexual health consultation and point-of-care testing, so rapid diagnostic test for HIV, syphilis, hepatitis, and also chlamydia and gonorrhea, as an outreach intervention to increase access to sexual health for migrants, displaced people, and other vulnerable populations. This is an example of the mobile clinic in one of the partners of the country's partner of our project. Going quickly to talk about Lebanon, because time is flying. This is a nice photo from the group, the Migrant Health Working Group mission in Lebanon in 2023. Unfortunately, because of the war, we didn't manage to go again last year in 2024, although we had planned a capacity building mission in May 2024 in collaboration with ILDS, IFD, Bridges, which is the NGO I co-funded, and other NGO, international NGO and local partners. The contest, as you know, probably you know, Lebanon is one of the countries with the highest per capita population of refugees in the world. We count to 1 refugee in 5 people, and over 1.5 million Syrian refugees, and now there were around 1 million displaced, internally displaced people. And the country really is affected by the war, the conflict in Gaza, and also the severe socioeconomic crisis. And there is a big dearth of medical staff in the country. I show you briefly the outcome of the mission that we ran in 2023. It was a feasibility and need assessment. We were mainly 6 dermatologists, so for over 400 patients during a 7-day field mission. And patients also in this case were mainly young, a lot of children, and in this case, not men, but a lot of women. A lot of single women because men were killed in the war, in the Syrian war, or because they were fighting, obviously. We also tried to assess the situation of women in the camps, and we found out that there was a high school dropout in female due to early marriage, poor access to contraception, with 77% of women interviewed denying use of contraception, although being multiparous and also sexually active, and little access to breast and cervical cancer screening. This was one of the outcomes of our study there. In Lebanon, as I say, I met Dr. William, who we identify, and we start a collaboration with. He was our local champions, and he helped us to continue our work, our project there, with the support of a teledermatology platform. We also ran a study on STIs, not only on skin, but also on STIs in Beirut, an observational and cross-sectional study between June and September 2023 in collaboration with an NGO in Beirut. Dr. William managed to recruit 95 patients attending Proud NGO in Beirut for sexual health consultation. And we also ran a CAP survey. So also person visited during the small pilot were mainly Lebanese patients, or less Syrian and other from other countries, and were mainly single, and they were mainly men who have sex with men due to the activities, obviously, to the Proud NGO characteristics, so an NGO that works mainly with the gay and bisexual population. The survey showed that there was a high level of knowledge of concerning STIs, but a very low use of condom prevention in terms of prevention of STIs. Many were attending also for the pre-exposure prophylaxis. 20% of the patients engaged in transactional sex, and there was again high stigma against HIV and a lot of fear about being recognized as MSM or being stigmatized for the type of sex they engage to. The skin disease diagnosis is a little summary about the skin, the condition of the skin we diagnose in Lebanon, mainly inflammatory skin conditions, you can see in this graphic, and in a bit less, around 20%, skin infection, mainly scabies or other bacterial and fungal infection of the skin. These are the main outcomes of the mission, the need assessment. Some photo during our field trip in the Bekaa Valley, children with bacterial and fungal infection. You see on the left a case of impetigo in a little child, and the Phthinia capitis, a fungal infection on the scalp on the right. And again, inflammatory condition, we saw these were prevalent. We have a case here of psoriasis and the lichen rubberplanus on the right. I go quickly. I don't want to bother you about STIs among LGBT, but we did, because we didn't have access to tests, so the diagnosis was mainly clinical. I put this to show you that one of the issue in countries like Lebanon or in other settings where there are poor resources, in poor resources countries, also the lack access to tests. So the fact that we had to use the syndromic management approach of WHO to diagnose and treat a sexually transmitted infection. Teledermatology is extremely important. We are collaborated with a provider, Consulta Connect, which is a telemedicine provider really transforming patient care in the NHS in the UK. So it's the biggest provider for telemedicine in the UK. And thanks to an agreement, Consulta Connect is provided in-kind service also to our project in Lebanon. We have 43 GPs in Lebanon that are accepted to be part of this net of Consulta Connect doctors. And for dermatologists in Europe, I'm proud of being one of them. In Malta, or they're from Spain, supporting the teledermatology consultation that we receive on a weekly basis. The Consulta Connect app was, the questionnaire was translated in English and Arabic, also to facilitate the use of doctors who are not fluent in English. The consultations are asynchronous, but the average time between when we receive a consultation, when we provide an answer is 7 minutes, so we are very fast. And we receive only complex cases, so far only 30 patients, but quite complex cases in the last 4 months. And I quickly conclude saying that in Malta, so we have seen, I show you the work of these two countries, very different, both countries facing in the Mediterranean Sea. In Malta, migrants from low and middle income countries have a higher prevalence of STIs compared to the Europeans counterpart. They have a higher prevalence, maybe because they come from countries with a higher prevalence, a baseline higher prevalence, but also because there is a big lack of knowledge, education. There is a need of health promotion strategies, increasing education and awareness about sexual health and sexually transmitted infection in migrants population. There is a lot of violence. I didn't present data, but we had other study and publication about sexualized violence and vulnerabilities, especially in female migrants. And there is high HIV stigma in the country of origin that also prevents from testing in the country, in the hosting country. The intervention to increase awareness and offer integrated community testing are very important. We are experimenting this with Reach Out. And it's very important because these people are usually left behind. They don't access our service, and we have to increase awareness and to increase access to the service, also reaching them out to the community and offering cultural sensitive services. In Lebanon, the teledermatologists help escalating the education, also in the training of non-dermatologists, GPs mainly, to treat skin condition in underserved areas. And we are expanded also this teledermatology project now in the north, in the Akka region, the north part of the country, with the help of a local dermatologist. And with this, I conclude. I really thank my colleagues listed in this acknowledgement part, and Dr. William also for being such an amazing champion in Lebanon, and the other colleagues who are following us in this important work. Thanks a lot for everything, and I'm ready to take questions if you have any.
All right. Oh, no, thank you so much, Dr. Padovese, as well as Dr. William Shahla. Yeah, this is really an important topic, especially in our countries here in Africa. I'm from South Africa, and we actually encounter the same challenges as well. Yeah, so I'm just quickly going to jump into questions. I've seen that Dr. Shahla already had answered a few questions. The first question was so that everyone can benefit. Is that do you regular use of oral ivermectin in treating patients with scabies? That was Dr. Amar from Egypt. Then your response was that the standard treatment of uncomplicated cases is usually topical permethrin 5% cream applied to the entire body and repeated after 7 days. The use of oral ivermectin in cases of severe or crusted scabies when topical treatments fail. Yeah, do you want to add anything into this?
I mean, yes, in my presentation, I added that we are seeing an increase of resistance to topical permethrin. And I found myself really in trouble because sometimes topical treatment is not available or really we run out of stock, we run out of treatment. And the only way to treat this case is oral ivermectin. So that is extremely important, yes. And I suggest also to increase the application of permethrin day 1, day 3, and day 7 instead of the classic day 1 and day 7, because in my experience it works and it helps to reduce the relapse or to treatment after treatment.
All right. No, thank you so much. Yeah, that really gives insight. And the second question was from Dr. Abdul Walil Pamao. He said that the dosage and application and resistance of scabies to permethrin, of which that's what you are also saying. So Dr. Shahla had said that the dose is 200 micrograms per kg as a single dose. Then you repeat after 7 to 14 days. Yeah. So it's just one more question, which is two, actually. What are the available diagnostic procedures at the disposal of practitioners in refugee camps and the sensitivity of the same? What can we use to diagnose? I'm sure you're talking about scabies.
I'm smiling because I think you have to use your eyes and your experience.
And your experience. Yeah.
Your experience.
Yeah.
And obviously important the clinical history, the history of itching at night, the history of itching in family member, the presence of lesions in the skin in family member, sharing same space, overcrowded space. This is also quite common in the history of these people. And you see a lot of children also with lesions, so all the family usually is affected. And the typical night itching and the genital lesion, as Dr. William has shown in his case, are also typical. So don't be afraid of asking to the patient if he has itching in the genital. Most of the migrants refer to me, since I work at the sexual health clinic, they have only genital lesion, and that our doctors here are not able to recognize scabies because it's only in the genital, and they're not used to see this presentation. Obviously, after the genital location, scabies spread after a while all over the body. But we want to do an early detection to prevent, obviously, the spreading of these communicable disease.
All right. No, thank you so much for that. Yeah, there are just also other questions. I'm sure due to time, maybe I might not be able for us to get through them. The most important one is: there any change in epidemiological patterns of the diseases treated amongst the refugees over the years? And if so, what are they? And do they mimic other diseases patterns elsewhere, or these unique to camps?
So this is a difficult question.
Yeah.
So we have seen, and it depends a lot from the country where we are working. So like obviously in Lebanon, we observe an increase, especially recently with our teledermatology project. We are seeing an increase of the skin infection. So in the field assessment during the first mission 2023, we had noticed a higher prevalence of non-communicable diseases. Okay, because we were seeing Syrian refugees mainly living for over 10 years in the same area. Whereas now that people are moving and usually finding a shelter in a school or living all together, hosted by friends and moving, and they are more displaced, we see an increase of communicable skin diseases against scabies, also fungal infection, an increase of fungal infection, and also an increase of fungal infection resistant to treatment. The same we have noticed in other refugee settings. We were working in January, we worked in Tanzania, and we saw a very high number of skin infection, mainly fungal infection of the skin was the first disease reported, and then scabies and other communicable disease. So these are the main problem. The same we have faced in Cox's Bazar in Bangladesh when we were working with the Rohingya refugees. A huge number of fungal infection resistant to common antifungal treatment. I'm talking about oral antifungal treatment, not topical.
All right. No. Thank you. And just the last one, or maybe from my side, just wanted to ask, how many dermatologists do you have? I'm sure that you are doing a study there, and versus the population that you have. Is it the 42 million that you showed in the study, or is it more?
How many dermatologists?
How many dermatologists do you have in your country? And how many are able to visit this in the camps, the refugee camps?
In which country? Malta, you mean?
Malta, sorry.
Malta is a very small country, and my colleagues are not willing to work in camps. So I'm the only one, I must say, unfortunately.
Sure.
So there are no dermatologists. That's why we need to scale up the training of non-dermatologists. And we are collaborating a lot with primary healthcare doctors, with GPs to work, and we train them how to recognize skin condition in different skin tone, and also about the sexual health and STIs, because there are not many specialists and they are not interested, or really, I mean, it's difficult to engage with the population with different cultural and religious background, and obviously is not much rewarding in terms of income, let's say, whereas dermatologists deal mainly with aesthetic, cosmetic, and other things. Unfortunately, not many dermatologists like working with like me or William with the communicable diseases and vulnerable population. Let's make a difference, in my opinion. Also the sensitivity of the person. So, but there are amazing GPs that are very happy, willing to work with migrants and refugees. They want to be trained. There are doctors working with NGOs that need training, and this we are addressing our efforts to scale up training of doctors or non-dermatologists working with the refugees and displaced people.
Hopefully in 2025, this year.
Yes, I hope.
Yeah, awesome. Yeah, probably this is for you, Dr. William, as well, so we can bring you in. Are there any country health policy agendas specifically handling treatment or refugees in your place of work, or are these handled by WHO? This was by Clause B. Yeah.
So, sorry, I think I didn't get it. Can you say again?
It says that, are there any country health policy agendas specifically that are dealing with the treatment of refugees in your country, or is this handled mostly the policies by the WHO bodies?
No, I think mainly UNHCR. I'm not sure I understood the question, but it's mainly refugees' health, migrants' health fall, especially in the camps, under UNHCR, not under WHO. So most of the time we collaborate with UNHCR. What I mentioned before, we are collaborating with the ILDS is in an official relationship with WHO concerning the improvement, the access to skin health for all. And we are collaborating with WHO to improve access to skin health, also supporting the development of the skin health hub used by healthcare providers, non-dermatologists in the field. It's a very easy to use app. Anyone can download it, and I invite you to download it. it can really help and guide the diagnostic process based on symptoms and signs of the skin. You can find a lot of photo and also the differential diagnosis process. There is a doctor collaborating with us as a migrant cell working group and IFD to develop an artificial intelligence component in this app. And through this artificial intelligence, you can take a photo of a skin lesion or a dermatitis, and the app can give you an idea of the differential diagnosis and the most probable diagnosis. I mean, the same mechanism an expert dermatologist can do, the differential diagnostic process. What Dr. William explained when we was talking about differential diagnosis, for instance, of cutaneous leishmaniasis. And the app tell you this can be 80% cutaneous leishmaniasis, but 20% can also be skin cancer, and give you an idea of what you should do, and the important thing is follow up the patient and then refer for biopsy, or it give you a suggestion about the treatment. So it's a very useful tool for non-dermatologists or for dermatologists who need to enhance their training on dermatology of skin, neglected tropical disease, and in their differential diagnosis also common skin conditions.
Yeah. All right. Now, thank you so much. I think that was the last question. Thank you so much for the beautiful presentation. We've learned a lot. I'll hand over back to Karen. Karen?
Thank you so much, everyone. Thank you especially to our speakers, Professor Valeska and Dr. William. We're very grateful for the presentation. Maybe more of us will be inspired to join this migrant health STIs and HIV.
Yeah.
That's the purpose of it.
Migrant Health Working Group. You are all welcome. I really hope that people can contact me. There was an email, or feel free to message me. Our group is growing, and you are welcome to collaborate and to help, to support. Thank you.
Okay, thank you. So
thank you, everyone.
So just to share my last slide. So thank you everyone for joining us. If you want to get more information on our webinars, they're all recorded and they're available on YouTube. And you can get more information from our pages on Twitter and on Instagram and on Facebook. So follow our handles. And we also have our website where you can get more information. Thank you also to our supporters, Sarah V and the Ellis Foundation. Thank you everyone. Have a lovely day, night, evening. Thank you.